Hello, and welcome back to another episode of Straight Up with Steph. Today, we're talking about assistants scaling teeth. More specifically, the new Oral Preventive Assistant initiative brought forth by the American Dental Association. If you don't know what I'm talking about, it is part of the Dental Access Model Act, but I put a link down in the show notes so that you can read all about it. But it's gotten everyone into kind of a tizzy, understandably. And I wanted to bring on an expert today that could talk about it, not just what it means for dental hygienists, but also dental assistants, dentists, and just the whole state of dentistry. To me, honestly, it seems like more and more of these things are popping up. And this is a nationwide initiative. So this could have a significant impact on our industry. But I feel like the floodgates are open and we're just going to be seeing more and more of this. Alyssa Aberle is my guest today. She's a return guest. I talked to her last time about internationally trained dentists and dental students doing hygiene duties. If you didn't listen to that episode, it does provide quite a bit of background for today. So I'll link that down in the show notes for you too. I feel like the field of dental hygiene and really dentistry, we're just at a crossroads right now. And I think the things that we do now or within the next couple years are really going to shape the future of our industry. Alyssa and I talk all about this new legislation and also what the average hygienist can do to voice their opinion, and also what states can do to really just reshape the role of dental hygiene within their state. I put a lot of episodes out and I love them all, but this one is a must listen if you want to understand the current state of dentistry and also where the future of our industry is headed. I hope you enjoyed today's conversation with Alyssa. Hey, it's Steph, and welcome to the Straight Up with Steph podcast, where we have real discussions around health and life and just trying to be better at both. Hello, Alyssa. Thank you so much for joining again. I feel like we just talked, but we have a lot to talk about today, so thanks for coming.
Absolutely. I know it's like we just talked not that long ago, but a lot happens. So it's always good to touch
Yeah.
base again.
Last time we talked about the internationally trained dentists and dental students potentially being allowed to take over some hygiene duties. And just, I guess, a recap or update on that. Are there any updates on that?
Well, so ADA, as we talked about last time, and if you haven't listened to last time, go listen to that for more
Yeah.
understanding of that. But they had passed a resolution in their House of Delegates in October, which just basically says that ADA as a whole would support legislation at the state level to allow these types of things. The one thing that kind of has updated on that since then is that Massachusetts, they had introduced a bill back in July, but it did pass through their second house of their legislature just in the last couple of weeks. And so I believe that's moving to their governor's desk. And it would allow dental students and foreign trained dentists to get licensed as hygienists. The Hygiene Association there was successful at making sure that the same board requirements existed. So they would still have to pass the same board exams and the same licensure requirements as far as whatever else is required in their state. So they were happy with that they made sure that at least those exams are in place that we talked about last time. I do anticipate other states talking about this and considering pursuing this type of legislation. There's been a lot of conversation on social media, Facebook groups and stuff like that, both pro and con arguments. We're just going to kind of have to see how each state wants to handle it. I think the same concerns and barriers keep coming up. Is the first one is that licensure requirements, is making sure that those are there. Two is, how do you quantify if the education is the same as it is here or equivalent in some way? What if those dentists come from a country where they didn't learn as much prevention or subgingival scaling or some things like that? So how are we going to address that if those things happen? And then does it even address the issue, the shortage, especially with dental students, as we talked about? Like, I don't know a whole lot of dental students who have a lot of time to work as a hygienist, maybe
Yeah.
temping, on breaks or filling in an office, but that's not going to solve a workforce shortage or a workforce issue on a large scale. We'll just kind of have to wait and see how it all
Yeah.
plays out.
Yeah, and for those listening, if you haven't listened to that episode with Alyssa, I'm gonna link it in the show notes because some people might be like, "Wait, what?" But definitely go check that out, and I can't imagine as a dental student, like, then being expected to do hygiene. I know the hygiene school workload was crazy, and I just can only
Mhm.
imagine dental, and I'm like, I don't know if this is really the best solution
Well, that
for
was one of the
everyone.
conversations in it's a primarily dentist Facebook group, and they were having that same conversation because they've been talking about for several years how they feel like the requirements for dental school have just kind of gotten lessened and lessened and lessened as well due to faculty or time or whatever resources they have. And so dentists are coming out with only doing one endo during dental school or not doing any fixed prosthetics, and so there's already dentists graduating who feel like they're not getting enough dental education and practical experience. And so they're like, so now we're going to take time away from pouring into what is going to be our profession and our craft and try to figure out how to also be a hygienist when if everybody's able to do what they are educated and licensed to do, hygienists doing hygiene and periotherapy frees up those dentists to do those more complex restorative procedures. So, yeah, the dental students and new grads are kind of in the same boat. They're like, whoa, whoa, whoa. We already are trying to figure out how to get more experience with the restorative. If they already were a hygienist before, that's, maybe a different story, but they're already usually licensed as a hygienist. So, yeah, they're expressing the same concerns and frustrations.
I bet it's just I don't know, it's almost like throwing stuff at the wall, just, like, see
Yeah.
what sticks, you
Yeah.
know? And
Yeah.
really, ultimately, with all of this, it's like, yeah, it's distressing for us in the industry, but who is the ultimate person who's gonna feel the effects of this is the patient. Yeah,
And
which
I
is
think
what
the
concerns
patients
me.
probably already are feeling some of it, because I talk to friends and family who are like, if I cancel my dental appointment today because I'm sick, I know I can't get back in for 5, 6, 7,
Months.
8 months. Yeah.
Y
And so they're already starting to feel that tension. They don't always know where that tension's coming from, though. So
yeah.
they're being told, oh, we have to reschedule you because we don't have a hygienist. They don't always know why. There's sometimes reasons why an office doesn't have a hygienist. Sometimes it's a location issue. There's a lot of reasons, but all they know is they're being told there's no hygienist. So, yeah,
Yeah, and then they have to wait months, and then they come in and maybe things have taken a turn or you know
right.
what I mean? It's just yeah, this whole thing. Okay, so today what I really wanted to get into was the Dental Access Model Act. Specifically, because there's a few different things in that act, but specifically I want to talk about the OPA or the Oral Preventive Assistant. So can you tell
Sure.
us what that is?
Just a little bit of background. The Dental Access Model Act is model legislation that was brought forth, from my understanding, by the American Dental Association to a legislative association called ALEC. They are an organization that's nonpartisan. Their members are legislators and stakeholder associations. And so they come together and they create model legislation or ideas or draft policies that then they hope that their legislators can take back to their states and implement at a state level. So this is a common practice in state legislation. It doesn't make sense for a state legislature to create something from scratch if there's already models in place in other states that are being successful. So this is a common practice, but this specific model legislation has three parts to it. There's expanded function dental assistant draft, oral preventive assistant draft language, and then some language around teledentistry that can be implemented at a state level. So, what you were asking about specifically is the second one, which is the oral preventative assistant. And this draft legislation regarding oral preventative assistance, I think, is like 2 paragraphs. It's pretty short.
And
So,
it's
it's
very
pretty.
like vague.
Yes, it's very short,
Yeah.
very vague, and so it proposes a model where there would be kind of like a mid-level assistant. Expanded function dental assistants tend to be more on the restorative side, as we've experienced here in Colorado and many other states. They tend to be able to do place restorations, do things with a little bit more technical skill and some autonomy in certain situations. But the oral preventative assistant is kind of like expanded functions dental assistant, like pre-hygiene almost. So that dental assistant role would be able to scale teeth, remove calculus, and probe, do periodontal probing. But again, they left it pretty vague. It does say like up to state rules and standards, which leaves it pretty open for the states to decide what works. I will tell you that ALEC, this organization that considered this draft legislation and did end up adopting this draft as something that they supported, they tend to be more conservative leaning as far as less governmental barriers, more state autonomy. So this kind of lines up with that, is like you kind of want it to be vague because you don't want to tell states what they have to do or
Yeah.
exactly how it should work in their state. You want the state and their legislators and their members to be able to kind of figure out what works within their own state environment. So I think that's why it's vague. But of course, for us as hygienists who went through a lot of education and have lots of licensure requirements, vague sometimes leaves the door open for something else. And so the vague is always a concern.
I always try to not be neutral, but to give people the benefit of the doubt. And I try not to get too emotional right away or whatever. But when I was reading this, I had like a visceral response. I'm not only concerned about what this means now or for the next few years, but what does it mean later when it's like, oh, well, they can go sub,
Uh-huh.
they can go ahead and do root planing. I almost feel like it could open the door for that kind of thing too.
Yeah, I think again, that's where kind of the vagueness of the language can be a concern. I know when we went through a process in Colorado here last year where a similar model was proposed to our Department of Regulatory Agencies, that was a lot of the conversation, was that is a broad category. Like calculus removal without specifying what the diagnosis of the patient is could mean SRP. It could
Mhm.
mean some more advanced things that take a lot more understanding of the periodontal pathogens and the anatomy, and could it require local anesthetic? Like there's just a lot that kind of goes into those more advanced cases. And so by leaving it open to that, especially, there's a concern. One for the profession and the standards that we have currently, and again, for the patients, because they don't always know the difference in the different roles and the different
Yeah.
education. I mean, how many times a day are we like, yes, I'm a dental hygienist. No, that's not the same as a dental assistant. No, I don't
Yeah.
want to grow up and be a dentist. Like I
I
chose this
know.
profession. And so I think sometimes that's already a confusion. And so the patients may not know the difference in that. Another conversation that I heard a lot when we were talking about it in Colorado last year was hygienists who said, do you know the amount of time that we spent in school learning how to probe properly? It seems like it's such an easy thing, and especially if you're just watching somebody do it, you're like, they're just yelling out random numbers, and they're
Yeah.
just, like, rolling along the teeth, but the pressure that it takes, the angulation, the calibration between providers to make sure that those measurements are accurate, because 'cause we're talking in millimeters, like,
Yeah.
these are small gradients, so you really wanna make sure that that person gets adequate training to do that properly, not cause more damage, get accurate readings, because those readings lead to a diagnosis, and
Mhm.
that diagnosis follows that patient. It's hard to separate that piece of the assessment from the whole picture of the diagnosis and treatment. So yeah, there's more concerns here, whereas like with some restorative procedures with an expanded functions dental assistant, I've worked with a lot of expanded functions dental assistants. The dentist comes in, they're doing the diagnosis and the assessment, they're prepping the tooth. The assistant is coming in and placing and shaping the restoration, and the dentist is following up on it. It's a lot harder to do that type of supervision with procedures like scaling and probing because you kind of have to stand there the whole time and watch it happen. It's not like a multiple person process. It's usually something that one person follows through. So, yeah, there's some concerns with the logistics and how that would actually get carried out.
I was on a Zoom call a little bit earlier with a dentist, and he was not aware of this. And so I brought it up and we just
Uh-huh.
started talking about it. And when we're talking about probing, there was some verbiage in the OPA section of that act saying that they would only stay supratingivally and that they would be probing to assess disease. And I'm like, if someone doesn't know what they're looking for, probably everyone is going to be quote unquote healthy. And we all know the numbers. Most people are not healthy. I saw in that act too, they would be, staying super gingivally and that they would only be working on healthy patients. And I'm just like, I don't see it. Is someone going to come check to
Yeah.
like probe and make sure? Or are they going to stand over their shoulder to make sure that scalar does not go sub? Like, I don't understand it.
We have seen so many, as hygienists, patients who, when they first get leaned back in our chair and we're starting to just do like even intraoral exam, you're like, oh, things are looking okay. And then you start probing and you're like, well, my probe just fell in that hole.
Yeah.
And you start seeing the bleeding and you start seeing a lot of things. And so sometimes it is kind of deceptive when a patient presents because there's a lot of different factors that play into their diagnosis and their disease process. And as far as supergingival scaling, I've said this for years. I think that that is just a fallacy of even a term because there is no such thing as
No.
supergingival scaling. There's no way to stop at the gingiva because very few times does the calculus just stay supergingival.
Yeah.
And in order to remove that calculus, you usually have to go underneath the piece of calculus to get the leverage to remove it, especially if it's heavy or kind of that ledge or ridge of calculus. So it's almost impossible to only scale super gingivally. I actually tried this one time at work. I had a patient and I was like, okay, I'm going to go through one time, like with a scalar or Cavitron, and see if I can only scale above the gum line. And then, of course, I'll go back and finish my own work. It was my own little experiment. But it's almost impossible because your
Yeah.
scalar and your Cavitron tip and whatever you're using, your Explorer, it will fall to the bottom of that piece of calculus just naturally, and it's gonna go subgingival. There's no alarm that goes off once you cross the gum line. So,
Right.
again, like, somebody would literally have to stand over you even with a camera or something, because even if you're in the same room, you don't know really what's happening. So, I've always hated that term, supragingival scaling, because 'cause I'm like,
Yeah.
that's not a thing. Like, I get lower anterior lingual calculus pretty quickly, and even mine, I'm like, "You gotta get a little bit under that gum line
Yeah.
to
To
get
like
that."
get it out.
Yeah,
Yeah.
so I just think that that's kind of a crazy concept that we think that that's even feasible.
I know, and it's even when you're polishing, you're going sub.
Yeah,
I mean, like, for some people, that could be, like, a big deal if they've
yeah,
got a lot of inflammation or whatever. Something else in that that I had an issue with the OPA verbiage was that for the first 5 years after they
uh-huh,
get, like, licensed or whatever, they could only work in public health, and that was another thing that I was just like it made me almost, like, physically sick when I read
yeah.
that.
You
I
you
don't
and I
agree
have
with that.
talked about this off the podcast. So, I have worked primarily in public health for my entire dental hygiene career. I've worked for several federally qualified health centers, and one of the things I'm really proud of here in Colorado is that our Practice Act does not delineate between income levels or geographic areas or federally qualified health centers or HIPSAs versus other types of practice. If a hygienist or an assistant or a dentist is able to do something in a private practice, they're able to do it in a federally qualified health center and vice versa. And to me, that is the standard that we should have because that's providing equitable care to all of our patients. I don't think that patients who have a different income level or a different level of coverage or live in a different part of your state should have a different standard of care or a different standard level of provider. I think that everybody should be able to access the same type of care. Now, do I think we should try to incentivize people to serve these underserved populations and try to find ways that that would be sustainable for providers to want to go serve those patients? Absolutely. That's my whole career. That's what I'm super passionate about. But I don't think that the way you do that is by limiting them to those
Yeah.
populations. And I don't like when we start saying these patients get this, but these patients get this. I don't think that that's fair or right for our patients.
Yeah, and I think that's why I had the reaction that I did.
Yeah.
I'm just gonna say this bluntly. If the OPA becomes a thing, they would maybe be seen as like below a hygienist, right?
Uh-huh.
As far as like training and education. And then, but it's okay for this population of patients to get that, but
Right.
not people in private practice. I was just like, okay,
I know the intention is to
yeah.
address where the biggest need is. We have in Colorado, where we both live, we have whole counties that don't have a dentist or a dental hygienist in them. The concern is how do we get care to the people that need it? But I don't think you do that by limiting people to a certain area or changing standards for certain areas or groups of people. I think you do that by trying to address things like sustainability of a practice, reimbursements from insurances,
Yeah.
loan repayment opportunities, business incentives to make practices want to think outside the box with different models. I think there's a lot of ways that we can incentivize people to serve those underserved populations and get people the care they need. I just don't think this is the way you do that in an equitable and fair way.
Yeah, I agree with everything you just said. So I got some comments on Instagram when I got a lot of comments actually, but I picked some of the more popular themes, which we already talked about some. Someone was like, who's watching to make sure they aren't going subgingival? True.
Right.
Supragingival scaling is not helpful. We already talked about that. There was one comment though. They said, this has been done in Alberta, Canada. It works well in pedo and busy offices where the RDH can focus more on perio. And that's something that I kinda got from that the Practice Act 2 was, like, supposedly the OPA would work on the quote, unquote, "healthy patients," and then the RDH would
Uh-huh.
be focusing on perio only. What do you think about that?
I mean, I get that because this is what we're talking about with hygiene, or dental therapy or expanded functions dental assistants is if everybody is working to the top of their education and scope,
Mhm.
then it frees the next level, for lack of a better word, of provider up to do more advanced procedures. And then that next level then can handle the next, tier of procedures. My concern with that is that periodontal therapy is difficult. It is time
Yeah.
consuming. It is taxing on our bodies, as you know, because you talk about this all the time. And so to say that OPA would be able to do all the healthy patients and then you just stack hygiene schedules with 12 SRPs a day is unrealistic and
Yeah.
it's going to burn people out even quicker. We're going to be more at risk for musculoskeletal disorders. We're going to be more exhausted at the end of the day. And I think ultimately it will lead to more dental hygienists working less days clinically and pursuing non clinical opportunities. And so I think in a way, it creates more of a shortage, more of a void than
Hmm.
what we currently have. One of the things that hygienists really love and hygienists who are really thriving in their clinical careers is the variety. So I know you talked on your podcast with a hygienist from Kansas who's administering Botox and dermal fillers, which was a great episode too, if you want to go listen to it. But one of the things she talked about was those procedures add more variety into her day. So she can do periodontal therapy and then a healthy patient recare visit and then do a follow-up from Botox and then maybe do another periodontal therapy, but it gives her that variety in her not just like intellectual variety and like different challenges to think about and different ways to address patient needs, but also that physical variety. So you're not just sitting for 2 hours at a time. And so I think if you create this position where a hygienist is only doing periodontal therapy, granted, maybe they would have some periodontal maintenance thrown in there, which maybe would be
Mhm.
some reprieve. But if you're just trying to do periotherapy all day, every day with no variety, it will get boring and it will get very
Yeah.
difficult on your body. And so that would be my concern is that we would see more hygienists working less days, having more injuries, and potentially leaving those clinical roles, which is really what we need to try to address is how do we keep the people we currently have in our workforce in their roles so that we can maintain our practices.
Yeah. I just wanna talk about one more comment. there was a lot of comments. This was the most popular. A lot of comments saying that this practice act or whatever you want to call it is for dentists looking for cheap labor. And it's like those kind of comments kind of hit me a little bit because I do
Uh-huh.
not like tension. I don't like,
Uh-huh.
people not liking each other, but I can see why people are thinking this. And I hate to say this, but I'm just thinking now the people who maybe think that this is a good idea, this OPA, still have no idea what dental hygienists do. If they think that we truly just scrape teeth, then yes, this probably makes sense to them, but we
Uh-huh.
do so much more than that.
Yeah, I mean, I have a hard time with those comments too because it feels more of like an emotional take when you start talking
Yeah.
about people and their worth and their value and what they should or shouldn't be able to make and for their career. That being said, I know hygienists who make a really wide range of salaries, and I know dental assistants who make a really wide range of salaries. I know dental assistants who make more than some hygienist friends that I have. And so
Mm,
I don't know that that's necessarily gonna do what people want it to do if that's the case. What I do think is that there has been a lot of conversation around hygiene salaries and how what hygienists are asking for is quote unquote unreasonable. And so there has been tension of if you're going to ask for this salary, then I can do this without you. And
mhm,
I think there's a lot of aspects. We touched on it last time in the other episode too, but one of the reasons that it is unreasonable is because of insurance reimbursements.
yeah,
And if those reimbursements stay the same or decrease over time, yeah, it doesn't make sense to pay somebody more than what the practice is bringing in for that procedure. However, that seems to be the issue is that reimbursement piece and the fact that you can't give your employees that cost of living increase at the minimum or a career ladder opportunity for them to grow. If you look at other professions, in other industries, there's usually a career ladder. Like you do
mhm,
this role, and then there's this next step, and there's this next certification, and there's this next tier that you get to work towards. In clinical hygiene, there traditionally has not been that
wow,
opportunity. And so hygienists they get bored, they get burned out, and it's fair and reasonable for them to expect that they should be able to maintain their mortgage or their rent because that stuff is all increasing.
yeah,
Nothing is decreasing out externally to our dental practices. The problem is that there's not that ability to reimburse more in most situations. And I think also outside of salary, it's that career ladder opportunity. So again, with that periodontal therapy hygiene position, people get bored. So I think what I've seen successful in some practices, and you and I have talked about this outside of the podcast as well, the practices that seem to be successful in retaining employees and keeping hygienists specifically are those who value them and give them some autonomy and are happy when they're learning a new skill, maybe support them in learning a new skill or getting a new certification. If you come into your practice and you're like, hey, I've been doing a lot of studying and I've taken a lot of CEs on airway, and I have all these ideas of how airway management could help our practice. And they're just told, no, we're going to do it this way because this is how we've always done it and we're not open to new ideas. That hygienist is going to feel kind of trapped and frustrated. And so the practices that seem to be the most successful are the ones that invest in the learning and the growth of their employees, not just hygienists, and value them and give them the opportunity to kind of have ownership and learn new things and implement new procedures into their practice. And so I think that's kind of more important sometimes than salary, but it goes along with it because it's that growth potential, that career ladder, that opportunity, and knowing that this practice values me and I can grow and learn here rather than this practice sees me as staying in my lane and staying in my box. And you will get frustrated and you will end up leaving that position. So I think
yeah.
broader than salary, we have to look at some of those reasons why people are leaving those clinical roles.
Yeah, that's so true. And I think trapped is a really good word because we make good money as dental
Hmm.
hygienists in most, I would have to say all states, probably, right?
Hmm.
And we have great hours, usually good days. But it's like some people, they're so burnt out and they're so bored and they hate going in, but they're
Hmm.
like, where else can I have this? And I get it. But on a more positive note, so when I worked for Dr. Brett, so Dr. Brett Kessler, the president of the American Dental Association now, I was his hygienist for a long time. And he was always so supportive because I would go to RMDC and I would take a class on occlusion. And I came back and I was like, okay, we need to get like all of this so that I can start checking the bite and I can start checking occlusion. He was like, okay, cool. And he was just so supportive of that. And then if I
Hmm.
wanted to do laser, he was like, yeah, let's go for it. If I wanted to do something else, he was so supportive. Like he didn't
Hmm.
care. And I just feel like me in that position, I felt like the sky was the limit and I was so
Hmm.
happy there. It's not like he was paying me $1 million
Right.
an hour, it was something else. So I think you're right about that.
Yeah, I just had lunch with a friend not that long ago, and we had the same conversation. She's like, she comes from a family that has lots of healthcare providers and other dentists and dental people in her family. And she was like, they keep saying you should go to this office because they advertise for this dollar amount per hour. And you should go to this office because they advertise for this dollar amount per hour. And she said exactly that. She's like, I've been with this practice for so long. They value me. I trust the dentist. I feel like they have really good ethics. They do good treatment. I would trust any of my family members to come here. When we bring up new ideas like guided biofilm therapy or laser, they're willing to invest in us learning about it and implementing the equipment. And she's like, I wouldn't trade that for any dollar amount. Like, it's
Yeah.
not worth it because I know that this is where I can stay happy and be in a practice that I can go home and feel good about at night, and that was worth it. And so I hear that so much on social media, and then you get it contrasted with the people who are like, hygienists are unreasonable, they're pushing themselves out of the industry, and I'm like, I don't think we're that complicated. I don't think it's that far away from where we all wanna be. We just have to sit down, like we said in the last podcast, and
Yeah.
talk about it because I don't think we're that far apart from each other.
I don't think so either. I think ultimately we probably all want the same thing, which is
Mhm.
interesting because we're like fighting so much right now. But moving on kind of from the problem, I wanted to talk about some solutions. I know you and I are we don't really like to complain. We just want to like fix the problem. So I hear these words being thrown around a lot: autonomy, advocacy, and then hygienists also needing to practice at the top of their scope. So, what does all that mean?
I know, it's funny because here in Colorado, I feel like this is just real life, normal life for
Hmm.
us. But then you talk to hygienists from other states and they're like, how does that even work? What does that even mean? What would that even
Yeah.
look like? So, autonomy is just giving people the ability to make decisions for themselves at a very basic level definition. So, patients have autonomy to decide what type of treatments they pursue or don't pursue. We as professionals should have autonomy over how we want to practice, where we want to practice, what we want to do. The problem when we start talking about autonomy in dental hygiene is that traditionally dental hygiene as a profession has not had autonomy. So many parts of our career and profession are determined by the dental association or by dentists. So our CODA accredited education, CODA is the Commission on Dental Accreditation, which is underneath the umbrella of the American Dental Association.
Hmm.
Our licensing exams, the National Dental Hygiene Board exam, which is our national written board exam, is administered by an entity that is part of the American Dental Association. Our state dental boards often are mostly dentists. Some states have more hygienists on their board than others. Some states don't have any hygienists on their dental boards. So the dentists, even at the state level, when you start to get licensed, are determining what licensure standards you have, what your scope of practice can look like. And then once you get into practice, of course, in most states, a hygienist still has to work under the supervision of a dentist. So even in a practice, nothing you say is the final word. You always have to make sure that the dentist supervises it or approves it or collaborates with you on it. And so many points in our career path, it is controlled or determined by dentists. Whereas nursing, physical therapy, all these other healthcare professions, they have their own boards. They have their
Mm.
own entities that are creating their licensing exams. They have their own accreditation organizations that are determining their educational standards. And so when ADHA is talking about autonomy, that's what they're talking about, is that we should be having more of a voice in those different points in our career path and getting to say what we feel is the appropriate standard for dental hygiene as dental hygienists. So that's what we're kind of talking about with professional autonomy. And then as far as advocacy, that can look like a lot of things. I always say you can start really small scale with advocacy, talking to patients, talking to family members. I feel like anytime a family member is like, well, what's the difference in a hygienist and assistant? I'm doing advocacy work because I'm
Oh,
educating
yeah.
them and informing them and giving them the information now that they can start to ask those questions. I went on a field trip with my 10-year-old on Monday, and there's a kid in his class, and the kid's mom is a dentist. And so he comes up and he's like, I hear that you're a dental hygienist. And I was like, I am a dental hygienist. He goes, my mom's a dentist. Can you tell me what the difference in a dentist and a dental hygienist is? Because I don't understand. And I was like, sure. So here's my little micro advocacy to a 10-year-old. But
That's
advocacy
cute.
can start at that micro level. It can be at a state level or a local level where you're talking to your elected officials about different policies or programs that affect our profession. And it can be at a national level, talking to national organizations like the Federal Trade Commission and the Centers for Medicare Services and different organizations that interact with our profession of dentistry and dental hygiene. So advocacy can be at lots of different levels, but it's speaking up and talking about how different things can affect our profession or how our profession can affect our communities. And
Hmm.
then the last one you said was,
Hygienists practicing at the
oh,
top of our scope.
right. We always talk about hygienists practicing to the top of our licensure, the top of our education, or the top of our scope. One of the things that we're trying to point out here is that with the Commission on Dental Accreditation, all dental hygiene programs in all 50 states have the same accreditation standards. So programs across the country have to include the same amount of education on things like dental hygiene diagnosis and treatment planning and, various aspects of our profession. Then once you get into practice, depending on where you live in the country, you may or may not actually get to utilize that education and knowledge in practice. And so here in Colorado, we have been a leader in practicing at the top of our education and scope. We have a really broad scope of practice. We can do most of it without the supervision of a dentist. But in many states, they learn dental hygiene diagnosis, they learn treatment planning, but once they get into practice, they're not able to actually do those things. So if the educational standards are the same across the country and everyone's learning the same, and last time I checked, people's mouths were the same in all 50 states, then you should be able to do what your education has taught you how to do. You are competent in it. You have proven that you're competent in it. You've taken board exams the same as everyone else across the country. We should be able to practice to that full scope. And again, that really does benefit the whole team because then it allows other providers to utilize their top of their education and scope as well.
Yeah, and across the country, it's just so funny. This is even in hygiene school, I was
Mhm.
like, I feel like this doesn't make sense. And I didn't even know anything back then. I went to school in Alaska and we were allowed to, I mean, I learned like placing fillings. We're allowed
Mhm.
to diagnose perio. I could give local anesthesia. Moved to Colorado, same thing, like very progressive practice acts. But then I'm like, most states are not like this. Like
Mhm.
most hygienists can't even diagnose perio, which blows my mind. I don't understand that.
Mhm.
And then, anesthesia and all that. So, what has to happen for all of the states to be on the same page as far as what we're allowed to do?
So I think that autonomy piece is a big part of it because if dental hygienists were overseen or regulated by dental hygiene licensing boards, then dental hygienists would know what the education and skills of a dental hygienist are and would be able to make sure that the state practice act, scope of practice, regulations align with what we know those standards are. Part of the problem is half the time we're trying to educate the dental board on what a hygienist actually learned. I've had a lot of conversations where somebody on the dental board is like, yeah, but how much pharmacology did you even get in hygiene school? And I'm like, the fact that you don't even know that, and then you're determining what we are or aren't allowed to do should be a red flag. So I think that autonomy piece is really big in that in healthcare. And I'm sure it's in other industries too, but you see it in healthcare and medicine, dental, whatever. There's a lot of turf wars or like, I want to keep my things to myself. I don't want to let anyone creep over here because they're going to steal all my jobs. And I think with dentists and dental hygiene, if we can show that actually a hygienist having more autonomy, more ability to work to their full education actually benefits us as a whole. It benefits the dentist, it benefits the practice. In Colorado, it allows us to think of different types of models for our practices. So I work for a dental hygienist owned practice. We don't have any dentists. It's a few of us hygienists that go into facilities, senior nursing facilities, and homeless shelters, and we provide care. We have a dentist that we refer our patients to that we have a really great referral relationship with. And us going to where people are and connecting with them and starting that process, getting them into the like funnel of dental care and then helping them get to the dental office is so much more beneficial than just handing them a card and saying, okay, here's a dental office, figure it out, because it's difficult for people to figure out. So, us being able to work without a dentist and have more of that control actually benefits the dental practice because by the
Mm.
time they get there, that practice has done zero marketing to get that patient. They come in, they've already got all their x-rays, perio chart. Mostly they've had their hygiene treatment done, whatever that was determined to be by the hygienist, and they're ready for that restorative care. And we've usually kind of prepped them like, here's what we saw in the x-rays. Here's some things they're going to talk to you about. So by the time they get to the dental office, they go in and they're like, yep, I know that I'm going to need this, this, and this. And the dentist doesn't even have to really convince the patient. They're
Mm.
just ready. And so having that autonomy and letting people do what they have been educated to do in the long run benefits both of us. But we have to be willing to let go of some of that control and that territorial mindset, that scarcity mindset, and see that opening these doors could actually benefit all of us. It's not that hygienists are going to go steal all the dentist jobs. We're not dentists. Most of us chose not to be dentists for a reason. So
Yeah.
there's a reason that we chose hygiene. And so we're not stealing all your jobs. We're actually opening the door to think creatively about how our practices operate. And it could be beneficial for both of us. So I think long term, that's what's got to happen is we have to kind of all take a step back. And I'm hopeful because I see dentists like Dr. Brett and some of the dentists that I work with and refer patients to that are more open minded and see the big picture. And I'm hoping that over time, especially with like new generations of dentists graduating, we'll see people who are more willing to talk about what that could look like.
This dentist that I talked to earlier this morning, we were just like, people just need to be more like open minded. And we're so, I say the collective we, because we all kind of are guilty of this, is like we're just kind of stuck in our box and we're used to
Uh-huh.
how things have always been, but things need to change. So, what you mentioned about turf wars,
Uh-huh.
I think that's a really good example. But I'm just going to play devil's advocate for a second. And what would you say if someone was like, you're just against the OPA, whatever, because you don't want someone like stepping on your toes or stealing your job?
I've had that conversation with so many people because it's like, okay, we're saying that hygienists should do XYZ. Oh, but assistants can't ever do that
Right.
because we want to keep them in their box, right? And
Yeah.
I don't see it that way. I have worked with some really amazing assistants. I think any of them can and should continue their career in education. I think that they are very capable as a profession. My concern is that we get almost 3,000 hours as a minimum base level in dental hygiene education, 3,000 hours of dental hygiene education on calculus removal, diagnosis, treatment planning, how to periodontal probe, how that plays into your diagnosis. There's so much that goes into it. And so to diminish the dental assistants and say, you can do this in a 16-hour course, come to the Hilton on Saturday and get your certificate. Like, to
Over the
me, I'm like,
weekend.
that's not empowering them. That's not elevating their profession. It's cheapening it to some extent. And I think they are capable of learning how to scale teeth. I would love to be able to utilize people in different ways. I just want to make sure that that education and standard stays the same. And same when hygienists move into other roles as well. But when we're talking about hygienists having autonomy, we're not even talking about more education. We're just talking about letting them do what they've already been educated to do and what the accreditation agency has already said is the standard that we should meet. And then if you want to go on to other things like Botox or restorative or whatever as a hygienist, sure, there's additional education and training that should go into that. But when we're talking about this oral preventative assistant, I just don't want to see them also get put in a box and told, we'll
Mm.
let you do this as long as you stay right here, because I don't think that's fair to them either. And in a way, me advocating for not supporting this oral preventative assistant model, I hope that some people see it as we're actually trying to give the assistants a voice, because I don't think it's fair to them. I don't think that if they're taking on more duties, more responsibilities, more skill sets, that they should be paid the same that they currently are. So I think in order to do those things, yes, there should be a pathway. I just don't think what's currently being proposed in some states is the pathway that we should pursue.
Yeah, I've worked with some assistants too that I'm sorry for any dentists that are listening, but they have placed way better fillings than I've seen a
Uh-huh.
dentist do, like they can be very talented. But yeah, I agree with what you're saying. It's like, cool, if you want to advance, great. But it's like we have educational standards for a reason and we
Mhm.
shouldn't be like taking these shortcuts.
Yeah, I
Um,
think the other problem with the dental assistant conversation is that most dental assistants have never worked with a hygienist directly. They're usually working with the dentist. They're doing restorative procedures, they're doing surgical procedures. So, hygiene and periodontal therapy and prevention is sometimes not on their radar depending on the practice that they're working in. So, it's a bigger leap for them to figure out what that even looks like and learn that new skill set versus maybe moving into those expanded function dental assistant roles makes more sense as a next step, because a lot of them like the restorative piece. That's why they're doing dental assisting.
yeah.
That's why they're working with the dentist. They like that piece of it. So I think that's the other issue, is that their skill set, their knowledge, I mean, they can way surpass me in their understanding of dental instruments and products and what they're using for different things, because that's their expertise. That's where they've spent their careers. So the other challenge is hygiene is different, and most of them in most practices don't work directly with a hygienist other than maybe helping with charting or flipping over a room. They aren't usually working closely with a hygienist. So I think there's a whole separate skill set that comes with that that needs more than a weekend course in in how to scale a tooth.
Yeah, it is different. It's funny, I had several YouTube comments actually on our episode, and people were like, "Oh, internationally trained dentists are better than hygienists, and they're more than qualified to do the job." And I'm just like, I don't even respond because it's different. It's a
Mhm.
complete different mindset. It's a different skill set. I have a story about probing. I was at this nightmare office. We've all had those, right? And I was just working, and in the next operatory, I knew it was an assistant working on this patient. He was probing. I could hear him calling out the numbers. I got up out of my chair and I just went because I was like, no, this is crazy. And I went and mentioned it to the office manager and they, had a conversation about it. But he was like, well, Dr. So and so told me that I could do it. And she showed me how to do it. And I was just like,
Mhm.
this is crazy. I'm like, I'm barely out of school and I'm still learning.
Yeah.
This is like a skill that you learn over time.
That autonomy conversation comes into play again, because in some states, dental assistants are licensed or certified or regulated, but in a lot of states, they aren't. So for us in Colorado, they aren't. And so a lot of times they are trained on the job, and all they really know about what their scope is whatever the dentist that
Yeah.
hired them told them. And so I
Yeah.
think there's also this level, like with licensure, with certification, with more education, you start to develop that internal professional ethics piece, and they would start to have more ownership over, this is what I'm allowed to do. This is what I have been educated to do. This is what my licensure or certification allows me to do. And I kind of cringe when a assistant is like, "Well, I don't know. The dentist told me I'm allowed to do that." And I'm like, "But it's your career. You are the person doing the thing, and you should know what is or isn't allowed." And so again, I just hope that even though it feels like hygienists hate assistants, in many cases that's not it. And many hygienists were assistants before hygiene school. I just really wish that they could speak up for themselves too, because I feel like they're the ones getting kind of tossed around as like a playing chip here. And they are people and they have a career and they have a profession and they have families. And so I don't want them to get manipulated in this situation
Yeah.
either.
Yeah, I got a fair amount of comments actually from assistants, and they're like, "We don't want this." I
Oh,
think I even had someone who was like, "No one has asked us if this is something we
uh-huh,
wanna do." Like, they're already overworked too,
uh-huh.
just like the rest of us, right?
Yeah.
So, before we wrap up here, how can your average hygienist help with this? Either with the OPA initiative or, like, helping their state establish more autonomy?
Yeah, so I mean, like I said, I think there's different levels. Like on a micro level, talking to your patients about what's going on and what your education is at a very basic level, what you're able to do, what CE courses you've been to, what you've been learning. It starts to develop their understanding of what your role in the office is and what you have been educated to do. And I think ultimately, again, it's the patients that are going to be affected by this. So it gives them
Mhm.
the empowerment to know who's treating them. At a state level, I say this a million times, but join your state association. Chances are your state hygiene association is already talking about these things and already has either taken steps or is planning to take steps, but they need people and they need membership dues. So even if you don't have a lot of time to commit to it, even if you don't feel like you know enough about what's going on to really like testify somewhere, they need membership and they need engagement. So reach out to them and see what they're doing and see how you can help. Then sometimes they will need people to testify and speak on stuff. And so they need people with a broad range of experiences and education and training. I know when we were going through legislation in Colorado around lasers, I reached out to our friend Joy Rasky because I was like, I don't work with lasers very much in public health, but I know somebody who does. And so she really helped give testimony and speak on lasers and what that education should look like. So you may have some unique experiences that your state needs as an expertise role that could really help. And then at a national level, again, be a member of your association. ADHA is the organization that is advocating and speaking on behalf of dental hygienists. But like any organization, they can't do that without membership and membership dues. So join the association, get involved if you want and if you have time, but there are a lot of ways that hygienists can get involved. Then there are little things that pop up throughout the year. And if you're, especially if you're a member, you're going to know about them. So when this Dental Access Model Act kind of got on the radar back in December, the American Dental Hygienists Association wrote a letter to ALEC and to some of the key leaders in that organization. Then they reached out to our state associations and asked us as an association to do some letters and reach out to those legislators at a state level and the ALEC organization. And then many state organizations ask their members and hygienists to also write letters. So sometimes those things will pop up, letter writing campaigns, phone call campaigns, things like that, that are pretty easy for us. We had a template letter and we sent it out, and you basically had to kind of like plug and play some information about you and your career. And then we gave you the people that you needed to contact. So it's usually not too hard. It's pretty easy, but you're going to find out about those by being engaged and being a member.
And all of the changes that we want to see, right? Like hygienists being completely independent and able
Mhm.
to diagnose and able to go into a nursing home or whatever. It all starts like at the local and state level, right? As far as
Yeah,
like, okay.
yeah, absolutely. So, states, as far as professional licensure, have their own autonomy. So licensure is and probably always will be run by the state legislature and the state agencies. So it's easy to say we would like to make something universal across all 50 states. That's probably not going to happen when it comes to professional licensure, but we can show our state legislature, hey, did you know that 45 states allow direct access of dental hygienists? And that number could have been updated. So that, don't quote me on that, but they're like, we can use that and say, hey, this is what's happening in other states. This is what's working in other states, kind of like the model legislation we're talking about with the OPAs. You can use Colorado as an example. Say, this is what Colorado has been doing since the 80s, and it is working. And yes, we still have practices that have difficulty hiring hygienists. I'm not saying it's the end all be all solution. We still have things we need to work on as a state and as practices, but you can use what's happening in other states to say, hey, this could work in our state, or hey, we've seen this implemented in other states and it's not working. And here's why we don't think that our state should pursue that type of path. And so it really is at that state level where we're talking about scope of practice and licensure standards. So get involved with your state association. They're probably already doing a lot that you maybe don't even know is happening at your state level.
I remember when I got the letter from the Dental Hygiene Association here in
Mhm.
Colorado about the letter writing campaign. It was funny, like I printed it out and then I'm like, should I just write my own? Like this is this copy and paste. Like I didn't
Mhm.
get it at first. And then I don't know if it was you or someone else that posted on social media answering that question. It's more of a numbers game, right? Like if you get
Yeah.
2,000 letters from people, yeah,
So people always tell me, they're like, "Oh, I don't like the like form letter because I feel
yeah.
like if a legislator gets it, they're not going to read it. Their aide's going to get it and throw it in the trash." And sure, maybe that happens sometimes, but when I've talked to my state legislators, they're like, "Yeah, we get a lot of stuff, and honestly, we don't read it all. But what we do is there are certain topics that we can tell is a lot of interest in. Our aides will kind of start a tally count of, you've gotten 5 calls in support of this, but you've gotten 100 calls in opposition.
Mm,
And so they may not call you back. They may not know your name next time you see them, but they probably at least got a gauge on, my constituents really care about this issue. Or we didn't get any feedback on this issue. Probably nobody cares about it. So we'll just keep going. So sometimes not writing something or not saying something sends a message as well. And
mm.
so even a form letter is better than nothing, because silence means we're all good with it and we're not. So that your legislators usually do want to hear from you. Again, they may not be the one answering the call and they may not call you back, but they do want to hear from their constituents. And we should poise ourselves as, this is our profession. This is something we care really passionately about, and we want to tell you about what it took for us to become a hygienist, what we would like to see our profession be able to do. Here are some of the barriers that I've encountered. So they do want to hear from you. And silence, again, sends a message as well.
Yeah, that's so true. All right, Alyssa. Well, thank you so much for coming today. I mean, I just feel like shit's getting crazy. So I might ask you to come on again, like if something else
Yeah.
happens. But
In a way, it's kinda good, because I feel like there are times where, like, again, you don't hear anything, so you're just like, "Oh, nothing's happening." And
mhm,
sometimes that is what it means. Sometimes it means a lot's happening and no one has time to post it on social media. But I think in a way, we're kind of poking the bear in a way. We're getting conversations started. And whether that's the way we wanted it to happen or not, I give credit to ADA for trying to create a solution. I don't think it's the right solution. But again, we talked about this on the last episode. If you don't try something, nothing's going to work. So I
yeah,
do give them credit for trying to come up with a solution. I just think that there's research. ADHA and ADA did joint research on workforce issues. And the things that were brought up in that study have not been addressed in any of these proposals. So I'm like, there's information, there's data, there is research there to kind of show us where we should be headed. I don't think this is the right path to get there, but I do think that bringing up the conversations at least gets people engaged. And when everyone's engaged, we may get some good solutions that come up. And I'm excited to hear what people come up with and what could happen with it.
Exactly. This might not be what we want, but it could
Mhm,
be the impetus for us to really
mhm,
make these changes that have been due for a long time.
mhm. Yeah.
Yeah. So if people wanna pick your brain or contact you or just get in touch with you, what's the best place for that?
Yeah, so on Instagram, I'm Alyssa RDH, and I also am on a lot of Facebook groups. And so, Alyssa Aberle, you can find me on Facebook. Lots of people message me through social media as they do with you as well. I'm not quite as present on social media as Steph is, but I am active in those background conversations. So, feel free to reach out to me through there. And I'm sure Steph can link my email as well if you have questions.
Yeah, I'll put all of that stuff down in the show notes. Thank you so much, Alyssa, and everyone, thank you for listening, and we'll see you next time.